Welcome to Modern Medicine. I'm Dr. Dave Moylan, Medical Director of the Simon Kramer Cancer Institute in New Philadelphia. And it's with great pleasure I would like to introduce our guest for today, Dr. Rakesh Shah, who is a professor that I met a few months ago down at St. Mary Medical Center in Langhorne, Pennsylvania. I've been attending continuing medical education courses down there for the last few years. I have truly been impressed with the level of technical skill and research that is being done at a clinical hospital. Welcome, Rakesh.
Thank you. Thank you for inviting me. It's a pleasure to be here.
I would like to have you tell our viewers a little bit about your background, where you're from, what training and education you've had over the years.
So I've grown up in Philly all my life. I went to Temple undergrad, med school, residency, did my cardiology training at Temple as well as my interventional cardiology training, and then basically moved out into one of the suburbs around Philadelphia for my professional practice. And it's been a wonderful ride so far.
Well, again, I've been so impressed with the research that you're doing on a clinical level. I also note that you're director or chief chairman of the Department of Research.
Right. So I've been chair of our research advisory committee for a number of years, and part of my job is to not only bring in studies that we feel are clinically feasible, but also looking at the merits and safety of a clinical trial. Because after all, when we enroll patients in these trials, we have a responsibility
Absolutely.
to do justice to them and make sure that their safety is always accounted for first. So I also sit on our IRB for that reason.
And the IRB for our
Institutional
viewers.
Research Board, which is basically an independent body whose sole function is to ensure the safety of patients for clinical trials.
Now, you mentioned your educational background, which included Temple University. And by the way, my wife had gone to Temple, both the undergraduate school, the medical school, and had done her research training and internal medicine training at Thomas Jefferson across town. And we were just talking before the show began about some of the giants in internal medicine for which Temple was quite famous.
It really has been. It's brought out some incredible clinicians and researchers, which I think has served as an immense level of inspiration for me as well, to strive for the best, not only professionally, academically, but also for my patients. I think if I'm striving for the best outcomes come out for my patients as well.
Excellent. Well, I would like to talk about a new procedure that I saw showcased down at St. Mary Medical Center about 2 years ago, and I want to tie it into my other line of work.
Sure.
I'm Schuylkill County coroner, and I've been serving in that capacity for about 2.5 years. But one of the first cases that I had was a call to Frackville, which is one of our little towns around the center, and a gentleman was found dead in his home. And of course, we ruled out any foul play, but as is the case with most of these investigations, the key is to get a good medical history and do a physical examination. And we were able to speak to the man's cardiologist, and we found out that he had severe aortic stenosis. And I don't know how long he was being followed with that condition, but congestive heart failure had set in.
Absolutely.
And when I saw the presentation at St. Mary, I'm thinking, gosh, if we'd only known about that a couple months before.
Sure.
I wonder if you could comment on this gentleman's plight and tell us about the new technology.
Right. So aortic stenosis is well, let's start with the basics for our viewers first.
Absolutely.
Our heart has 4 valves. When we talk about the heart, think of it as a muscle, which it really is. The muscle needs an adequate supply of blood, but it also needs a regulatory system. So not only does it have a plumbing system, which is the blood supply feeding the heart muscle itself, but there's also an electrical system which helps regulate the contraction of the chambers. So the heart, if you think of it as a house, it has 4 rooms. two upper level rooms, two lower level rooms. And there's a left side and a right side. So the upper chambers of the heart are responsible for pumping blood into the lower chambers. So they beat first, and then the lower chambers pump blood out. The right side of the heart pumps blood towards the lungs, and the left towards the rest of the body. Now, to prevent blood from just sloshing back and forth, you need to have a regulatory system in there, and that's a series of valves that basically regulate the flow of blood. So on the left side, you have two valves, and most patients have heard about the mitral valve because there was a malady called mitral valve prolapse that was very much overdiagnosed for a number of years. And then there's also an aortic valve. This particular valve, the aortic valve, is supposed to open up nice and freely to allow blood to be expelled out. And in aortic stenosis, the valve narrows down significantly, causing a significant amount of obstruction and an overload on the pumping chamber of the heart, because now the valve is only opening up part way, in which case the heart starts to overload and patients start to develop symptoms such as congestive heart failure. Maybe they have angina, they may pass out. But so that's where the aortic stenosis comes in. So what you see here is a diseased valve. And basically what we're seeing is here's a mildly diseased valve, here's one that's severely diseased, where we have a significant amount of calcium on here. This should be a nice, smooth, glistening surface, similar to what you're seeing right here in the leaflets. Mm-hmm. But this degree of calcium prevents the valve from opening up freely. And this is what causes trouble at the end of the day. As patients get older, we're all prone to developing aortic stenosis. There are a number of other causes for aortic stenosis as well, but the most common is the senile variety, or where the valve has three leaflets.
How common is it? But it's something that general practitioners in our area would encounter with a fair amount of regularity.
Exactly, and it starts with physical exam. It really comes down to, like you said, diagnosis. We take a good history. Most of these heart valves are picked up on an innocent murmur as we get older, typically beyond the age of 40, 45. Mm-hmm. And when we start noticing this heart murmur, it initiates a workup. Most commonly, it's an echocardiogram, which is an ultrasound of the heart to assess the heart valve itself. Once we do that assessment, we're able to get an idea of how tight that valve is. Most of the times, until the valve is severely stenotic or critically narrowed or critically stenotic, patients really don't need additional therapy or treatment to take care of the valve because the heart can compensate reasonably well. The reason we don't fix these valves ahead of time is because there's no good data to suggest, hey, let's just go ahead and operate on patients, because if you operate too early, there's no improvement in outcome than when a patient starts to develop symptoms. So if a patient starts to develop symptoms, that's when you really want to work on taking care of them. And when they develop symptoms such as fainting, angina, shortness of breath, feeling lightheaded, maybe a rapid or irregular heartbeat such as atrial fibrillation, or palpitations, which may just be an uncomfortable awareness of their heartbeat, that's when you want to really start to think about an intervention. Exactly.
Well, Dr. Shah, we're going to take a very brief commercial break, but when we get back, I'd like you to tell us about the new approach.
Okay.
Welcome back to Modern Medicine. Today we have as our guest Dr. Rakesh Shah from St. Mary Medical Center in Langhorne, Pennsylvania. He's about to tell us about some rather cutting-edge procedures that are available to patients that suffer from severe aortic stenosis. Doctor, I remember in my training we would see patients coming back from the operating room after valvular heart surgery, and they would have an incision that would start from the sternal notch down to the xiphoid process. Oftentimes the procedure would be complicated by infection, or certainly a fair amount of post-operative discomfort, and they were laid up for weeks at a time. And as you pointed out, the aortic stenosis is a disease of aging.
Correct.
And older patients are probably less likely to tolerate such procedure.
Correct.
Is there a solution?
Sure. So there are several options. One, the first advice I would give patients is go with the technique that your surgeon feels most comfortable with. The second advice is if there's an option, just because somebody says you're inoperable or you're too high risk, there may be a third option available, which is what we provide at St. Mary's. You know, I'm fortunate enough to work with a group of partners at Comprehensive Cardiology who look at every single patient in a different light in that respect. You know, just because somebody's been told that they're not an operative candidate does not mean there's not an option available. And I'm fortunate enough to work with very talented surgeons who also feel very similarly along those lines. And when we look at these patients, we have a committee of physicians that review these cases on the high risk and inoperable cases and see what options are potentially available. So whenever somebody presents with aortic stenosis, we're not only looking at the traditional approach, which is the open chest approach, but our surgeons will also look at a minimally invasive approach, which is making a very small incision along the side of the rib cage and replacing the heart valve with that technique. And if they're not a candidate for something like that, and they're still felt to be high risk or inoperable, then there's a third option available, which is TAVI, also known as transcatheter aortic valve replacement. And this procedure really came about within the past 10 years or so as an infant procedure. We've been doing these procedures for approximately 2 years now, and rather successfully, and our data at our institution have essentially matched up with the clinical trial results as well. So one of the trials which was pivotal in securing FDA approval is called the PARTNER trial, and it was sponsored by a company called Edwards Life Science, and they're the makers of this prosthetic valve, which allows us to actually replace the heart valve with a new valve by going in either through their femoral artery in their groin or possibly approaching it directly into the chest wall and right into the main pumping chamber of the heart and implanting the device in the aortic valve itself in that same position while we just smash open, for lack of a better word, the pre-existing stenotic valve. And there's also a third approach where we can actually go in right into the aorta and replace the heart valve the same exact way. The real question to be answered is, why would we want to do this, right? The reason for doing this is when we look at the historical outcomes for patients with symptomatic aortic stenosis, once they start having symptoms, whether it's congestive heart failure, angina, or passing out, the mortality rate, in other words, the risk of dying, approaches anywhere from 50 to 60% within the first year, which is huge.
Yes.
You know, and this was borne out in the PARTNER trial as well. There was a 50% mortality rate in the inoperable control arm group.
I'm going to just parenthetically say, as an oncologist, that's a lot worse than many cancers.
Thank you for saying that. You're absolutely right.
Yep.
It actually has the worst mortality rate when left untreated compared to lung cancer, breast cancer, prostate, and everything else. Mm-hmm. You know, so you're absolutely right on the mark.
Now, you do have a animation here.
I do.
Could you walk us through that, and the
Sure. So
viewers can see it on their screens at home?
Absolutely. So what we have here are two different approaches. One, in the first case, if we start by accessing the femoral artery, and then we have our guide wire that goes up towards the heart, which then goes into the heart itself. That allows us to then bring in a larger sheath, which is basically a large plastic tube that allows us to deliver our balloons and devices the way we need to. So what we first do is advance this balloon into the aortic valve itself, and we start rapidly pacing the heart at anywhere from 150 to 180 beats per minute. The reason for doing that, when the heart beats that rapidly, it's almost as if it's standing still. And what that does is it causes the blood pressure to drop so that when we inflate the balloon won't champagne cork out because of the immense pressure. Mm-hmm. So once that happens, once we've dilated the valve, the balloon is then withdrawn, and then we go in with our valve. Once again, we use that rapid pacing sequence to drop the pressure and create almost a standstill environment, which then allows us to deploy the valve in that position. Once that's done, we remove the balloon, stop the pacing, and as you can see, the valve is functioning immediately.
I remember when you presented this at St. Mary, it was this 90-second period that put the gray hairs on yourself.
Absolutely.
Like, show
and
it.
I have a few of them to show for it. But it is an incredibly rewarding procedure because when these patients come back, they are doing incredibly well. When the procedure is an incredible success, the patients have a change in their lifestyle. A great story comes to mind where this woman could not walk more than 20 feet without getting short of breath, and now she's walking the mall. She's doing everything that she could possibly want to do. And that will to survive and do well drives her every day.
I have a second case here that I just want to review with you briefly. And this was a gentleman I'd seen 5 years ago with prostate cancer. And on the initial physical examination, I picked up a grade 1 murmur. And I just kind of filed that away. But as the years passed, it became much more prominent. And again, working with his primary care physician, he was referred to a cardiologist. Cardiac catheterization was performed. And he had one of those minimally invasive procedures. I'm not sure what the indications were. But he's ready to dance the jig. And he's 85 years old. And I think one of the beauties of it is he is not on Coumadin or warfarin or one of the rat poison blood thinners.
That's correct.
Can you tell us about that?
Sure. So that was a minimally invasive approach where the surgeon felt comfortable enough in the right anatomy to replace the valve with a mini sternotomy or mini incision along the side on the rib cage, which when done well is usually a huge success. Valves come in different flavors, if you would. Typically, in a younger patient, the surgeons will recommend a metallic valve, which requires them to be on warfarin or Coumadin as the brand name. But also, bioprosthetic valves are also very helpful. And the valve that we put in with the TAVI procedure, or TAVR, is a bioprosthetic valve made from bovine pericardium, which is a lining around the heart. But those types of valves typically only require aspirin after the procedure. Exactly. And the advantage to that is, one, there's no anticoagulation involved except for antiplatelet therapy such as aspirin. The downside to those valves is that they do have a finite life. They last anywhere from 10 to 15 years, sometimes longer, sometimes less. And so that is a rate limiting factor, and which is really why we don't use the TAVI approach for every single patient, because it hasn't been studied long enough.
Well, at age 85, if this man makes it to 95 or 100, he'll be very pleased. Well, it's time for another commercial break, and we'll explore some other aspects of interventional cardiology when we return. Welcome back to Modern Medicine. We have as our guest Dr. Rakesh Shah here at the Simon Kramer Cancer Institute, and he's been briefing us on some of the very innovative techniques for dealing with heart disease. But what I've found, especially in my work as a coroner, it is a continuum. I think cardiovascular or atherosclerotic cardiovascular disease is the real culprit here. And when we're doing a technique that we've helped to pioneer called the virtual autopsy, it's basically a post-mortem CAT scan. We start down in the lower extremities and we start working our way up, and then we start seeing the calcium coming in the femoral artery. Next thing you know, the iliac artery, and I can tell my deputies we're going to see that in the coronary arteries also. Correct. But you also specialize in peripheral vascular arterial disease. Can you tell us some of the newer approaches to that element?
So let's talk about some basic statistics of peripheral arterial disease. There are approximately 10 million patients in the United States with peripheral arterial disease. Basically, what we're talking about are blockages in the blood vessels in the legs, which are symptomatic or asymptomatic. of which only about 1.25 million patients go treated. So there's a huge population that still remains unserved or undiagnosed. So that in of itself, I think, partly needs to be corrected. Now, there are a wide variety of ailments that go with PVD. It typically starts with some sort of leg pain or cramps with ambulation or when patients are walking, which then can rapidly progress, especially in the face of diabetes and smoking, to limb loss and gangrene. Another sobering fact is up to 40% of the amputations in this country go without any arterial or PAD evaluation.
So basically what you're saying is you don't know what the real problem is, and yet you're lopping off an extremity.
Correct, and there's an opportunity to save these limbs.
Yes.
So this is where physicians like me come in. We're able to go in with our catheter-based techniques. I work very closely with my surgical counterparts and try to decide which patient is appropriate for surgery versus a less invasive approach. So perfect case comes to mind this past week. The surgeons had already turned down the patient. She was felt to be too high risk for surgery. They were worried about wound healing issues. And so I went in from an arm approach and fixed her iliac arteries, which are the blood vessels going towards the legs, all the way down to her groin, and restored the blood flow. Her foot pinked up immediately. She was at risk for losing her limb. So that was one of the saves that we had, and it's a great feeling because now all of a sudden we've gone from an amputation to this woman healing her foot wound, and literally the podiatrist who was taking care of her foot and the wound noticed blood coming from the wound itself, which is a great sign for us.
Yeah.
Otherwise, he was going to have to take the foot off. And we're able to do these procedures on a routine basis for a number of our patients and save a lot of limbs that way. In addition, another area that goes underdiagnosed is abdominal aortic aneurysms. So this is
That's
when
another coroner's case.
That's right.
See them too late.
So I also perform these types of procedures where the aorta may be aneurysmal or dilated or ballooned out, in which case we can go in with a minimally invasive approach from the groin to restore the restore the flow within the aorta and reduce the pressure on this ballooning aorta, which has a high risk of rupture because, as you know, when an aneurysm ruptures, the mortality rate approaches 80 to 90%.
80 to 90%.
And this is exactly what we're trying to prevent.
And yet when it's done electively, it's 2%.
Correct.
Yeah.
Exactly. And the minimally invasive approach has a mortality that's very similar to the invasive approach, which has traditionally been a long operation where the surgeons open up the belly, take out the aorta, and replace it with an artificial graft.
My late father had that procedure and knocked him for a loop for 6 weeks. He was flat on his back for 6 weeks.
Exactly. Patients, and as patients get older, and as you know, this is a disease of the elderly. Right? Approximately 12% of the elderly population over the age of 75, men over the age of 75, have an abdominal aortic aneurysm, which is a significant number. And the risks for it, any history of smoking, typically more than 100 cigarettes a day, age over 75, high blood pressure, and any family history are the big risk factors.
Is diabetes much of a risk factor for the aneurysm formation?
No, it's not. But it is for peripheral arterial disease.
Yeah.
And those patients typically have some of the worst arteries that are around because diabetes affects the small blood vessels as well as the larger blood vessels. And in some of those patients, I've even had to go into the pedal arteries and try to restore flow by going backwards because our devices are meeting so much calcium and hard plaque, which is essentially cholesterol buildup in the arteries, that we can't get through one direction. We'll try to go up from the foot if necessary.
You mentioned a couple minimally invasive techniques.
Mm-hmm.
One is the placement of the heart valve. One is putting grafts in.
Mm-hmm.
You also are experienced in atherectomy.
Correct.
Could you tell us about that technique?
Sure. So atherectomy is an adjunct to any peripheral vascular procedure that we do, or even in the coronary arteries and the heart arteries. Basically, we're taking a small burr, which has microparticles of diamonds on it.
Is that right?
Yeah. And they're spinning at anywhere from 80,000 to 120,000 RPM. And the idea is to shave away the calcified plaque and help restore some of the natural elasticity of the vessel in an effort to improve outcomes. So if we have to put a stent in there, in the artery, maybe we can get better stent expansion. Below the knee, many times I'm using the atherectomy with as an adjunct to using balloon angioplasty, which is to simply dilate out the blood vessel and restore the flow that way and try not to leave behind any stents. So each patient is individualized depending on the amount of calcium. What does this artery look like? Is there blood clot in there? Is there more hard plaque? Is there soft plaque? And what modality is going to be best for the patient for long-lasting outcome? Again, most of these patients are high-risk patients for a variety of reasons because they have a number of risk factors that predisposes them to stenosis. And as hard as we try to get these vessels open, sometimes they'll also narrow down from scar tissue or new plaque buildup, and we may have to go in repeated times to restore the blood flow.
The atherectomy and the diamond burr that's used, is there any danger that little particles could be created and they would get into the bloodstream further down?
Right, that's always a possibility. Thank God to date I've not had that issue. The particles are ground up into such small size that they typically filter through the capillaries and the body gets rid of the particles.
Doctor, could you just summarize for us the signs that patients should look out for that would tip them off that they're going to be at risk for the development or they're having early symptoms that would lead them to evaluation and perhaps correction before they have to risk limbs?
Sure. I think most commonly you start thinking about cramps with exertion or pain in the legs with exertion, typically the calf, or if it's the larger blood vessels involved in the iliac region or in the pelvic region, then the patient may complain of pain or weakness in their legs as well. As it progresses, the pain can become constant, and then it leads to gangrene.
Well, we want to avoid that at all costs. Doctor, I can't thank you enough for traveling up from Langhorne to be with us today, and I hope that you'll be able to come back for another session here in Modern Medicine.
Absolutely, would love to.
Thank you.
Thank you.
Thank you for joining us for another session of Modern Medicine. Look forward to you joining us again in the near future. Thank you.